Good morning, everyone. Myself, Dr. Rakesh Solanki, Assistant Professor, Department of Orthopedics, Index Medical College Hospital, Research Center, Indore. Today, we are going to discuss about fracture of the distal end of the radius. This is the outline of my presentation. Distal radius fractures are the commonest fracture presenting to the orthopedic trauma surgeons. And as populations continue to age and their activity level increases, the incidence of distal radius fracture is definitely expected to rise. The sound understanding of mechanism of injury as well as the modalities of various types of treatment for distal radius fractures is necessary for the optimum outcome of your treatment. Let us discuss about the epidemiology of distal radius fractures. It comprises around 17% of all fractures in adults. The age group, it is more common in elderly people after 50s and their 60s. It affects male in 40s and females in 60s. The male to female ratio is 1 is to 2 to 3. It is more common in females due to the presence of osteoporosis, especially around after the menopause. The majority of the fracture of distal radius are due to low energy impact, due to fall from standing height. The extra-articular fracture pattern is present in around 57 to 66%, the partial articular in 9 to 16%, and the completely articular fracture is present in around 25 to 35% of the fracture patients. Around 40% are unstable. The applied surgical and radiological anatomy, the distal radioulnar joint (TRUJ) is found by ulnar head and sigmoid notch on the ulnar side of the distal radius. The movement possible at distal radioulnar joint are pronation and spination, and the stabilizer is TFCC, that is triangular fibrocartilage complex. Severe radiological indices have been described which serve as guides to the normal anatomy of the distal radius. This includes on PA X-rays the radial height, radial inclination, and the ulnar variance. On lateral X-rays, the dorsal and volar tilt and the carpal alignment. These are the indices or radiological indices used to assess the fracture pattern of the distal radius. This is the X-ray image showing the radial height and the ulnar variance. And the radial inclination. The normal radial inclination is around 21 to 25 degrees on epiradiograph. The ulna is neutral or ulna is negative here. On lateral x-rays, one has to look for the palmar tilt, which is normally 11 to 12 degrees. Let us discuss the mechanism of injury of distal radius fractures. As most fractures are low energy injuries, very few are associated with high energy trauma. As we have discussed before, the risk factors are age, that is more than 50 years, especially in females with low bone mineral density and elderly with increased physical activity. Fall on outstretched hand with wrist dorsiflex to 40 to 90 degrees will cause dorsally displaced distal radius fracture. The sequence of mechanism of injury is force transmitted through carpus to dorsal part of distal radius. The volar cortex fails due to tension. Dorsal cortex comminutes due to compression. Fragment is displaced dorsally. The reverse occurs in fall on outstretched hand with wrist in volar flexion. The fall on outstretched hand with ulnar deviation causes the radial styloid fracture, and fall on outstretched hand with radial deviation causes the ulnar styloid fracture. The low bone mineral density is associated with increased fracture severity, increased risk of instability and comminution, and increased malunion rates. There are several associated injuries with distal radius fractures, and one has to carefully evaluate this type of associated injuries. The common ones are TFCC injury, that is the triangular fibrocartilage complex injury. It is the commonest associated injury with distal radius fractures. The ulnar stellate fracture increases the risk fivefold. Operative versus conservative management appear to have similar outcomes except for a slight reduction in grip strength in those conservatively managed. The intraosseous ligament injury that is most frequently injured are scapholunate and lunar-trochanteral ligaments. Positive ulnar variance of more than 2 mm increases the risk. No consensus on which is superior conservative or operative management for these intraosseous ligament injuries. The chondral injuries, not certainly on long-term effect of these injuries, thought to contribute to future joint degeneration. So these are the associated injuries with distal radius fractures. Now how to classify? So there are a lot of classification present for distal radius fracture. The Gartland classification that is based on comminution, displacement and articular involvement. The Frickman classification based on extents of articular and or ulnar involvement. The Fernandez classification based on mechanism of injury, and AO or OTA classification which is most widely used. The clinical features. Now on history, there is a complaint of pain and swelling around wrist. There is deformity, and one must ask for numbness and paresthesia of the affected limb, pain in other parts of the same limb, history of fallen out stretched hand. On examination, there is swelling, tenderness. The deformity present with typical distal radius fracture is dinner fork or garden spade deformity associated with Colles fracture. The radial deviation, prominent distal ulna due to shortening of the radius. Sometimes there is bluntment of the distal ulna, indicating the DRUJ injury. The check, one should check for the skin. One should check skin for the signs of any wounds, tenderness, the neurological examination of the affected hand. How to manage? The investigations are X-rays, mostly PAV of distal radius for extra-articular fracture. One has to assess the following: the radial length, ulnar variance, the extent of metaphyseal comminution or impaction, the ulnar stellate fracture location. On PAV, in addition, for intra-articular fracture, one should assess the presence or orientation of articular fractures, depression of the lunate facet, that is die punch fracture, the gap between scaphoid and lunate facet, for carpal stabilities, central impaction fragment, and carpal bone assessment. On lateral X-rays, the dorsal or palmar tilt is assessed, extent of metaphyseal comminution is assessed, the carpal alignment and displacement of the boral cortex is looked for. When to go for CT scan? CT scan is useful in articular fractures when surgery is being planned, measures intra-articular displacement more accurately than X-ray, also has superior demonstration of sigmoid notch fractures. When in doubt, go for CT. How to treat? The principal factor influencing the treatment choice is magnitude of demand placed on the wrist. The aims of the treatment are maximize wrist and hand function, optimize grip strength, preserve mobility. Primary objective is to restore the anatomy. The treatment is non-operative or operative. The non-operative treatment. 70% of the distal radius fractures are still managed non-operatively, and the indications are stable undisplaced fracture or displaced but stable after reduction. Involves close reduction and immobilization with a cast or splint. Manipulative reduction is done for non-operative management if the fracture is displaced beyond acceptable radiological limits. The radiological indices are positive Euler variance within 2 mm. Carpal malalignment is not accepted. The dorsal tilt should be less than 10 degrees if corpus are aligned. Palmar tilt, no limit if the corpus is aligned, and the gap or stepping joint is acceptable up to 2 mm. Where early reduction is needed to avoid complication, that is, for example, median nerve compression, even if subsequent treatment is planned. Reduction technique. It is done under hematoma block or regional anesthesia or general anesthesia or under sedation. Traction and counter-traction is applied. Manipulation of distal fragment is done. After chest X-ray, the immobilization is done in below elbow or above elbow slab. The outcome is around 59 to 92% is satisfactory and no benefit of surgery in this patient group. When to perform operative management? The indications are failed non-operative treatment and definitive or actual instability in the distal radioulnar joint. The predictors of instability are advancing age, that is more than 80% have the highest, more than 80 years of age have the highest risk, increased degree of displacement, metaphysical comminution, redisplacement following conservative management, and low bone mineral density. These are the predictors of the instability of the close treatment. The options for operative treatment are close reduction and percutaneous spinning, close reduction and external fixation, and open reduction and internal fixation. For decision-making purposes, they are divided into metaphysical unstable, extra or minimal articular fractures, displaced intra-articular fractures, and partial articular fractures. This is the X-ray picture showing metaphysical unstable extra-articular fracture. As you can see, the fracture is not involving the articular surfaces, so it is extra-articular. It is the metaphysis, so it is metaphysical, extra-articular, unstable fracture. The operative treatment. Currently, many still attempt conservative management. Treatment should be operative. Use of cast has been shown to be ineffective. Now, this is another X-ray picture showing complete articular fracture with fracture of the radial styloid, intra-articular comminution. In this type of fracture, treatment should always be operative. A study found that close reduction and percutaneous fixation had better functional outcome than open reduction and internal fixation. Some authorities therefore recommend attempting the former first. If unsuccessful, then ORIF should be done. The only exception being elderly, frail patients who are not fit for surgery where cast immobilization would have to suffice. Now, for partial articular fracture, if there is volar shear fracture inherently unstable, treat by open reduction internal fixation with volar plate. Rarely, undisplaced fracture may be treated conservatively. If patient is having dorsal shear fracture, usually high energy injury occurring in young people, treatment is open reduction, internal fixation with dorsal plate, volar, or both. The radial styloid fracture is, if undisplaced, is immobilized in cast. If significantly displaced, treat operatively with percutaneous spinning or a screw. If close reduction is not successful, then open reduction and radial buttress plating may be necessary. How to rehabilitate, or what are the prognosis after fracture management? Following non-operative treatment, monitored by X-rays at first week, second week, and third week. Cast is left for around 6 weeks, and active mobilization starts as soon as the cast comes off. And following operative treatment, active mobilization begins as pain permits. No loading, however, is permitted. Now let us discuss the complications of these types of fractures. The carpal tunnel syndrome, nerve injury, median nerve injury is the commonest. The ulnar nerve injury, tendon injury, extensor pollicis longus tendon injury is the commonest. Lewis compartment syndrome, malunion, non-union, and complex regional pain syndrome. To conclude, distal disc fracture will continue to be a problem as life expectancy increases. Today's orthopedic trauma surgeon must be adept in its management. Thank you very much.